My name is Dr. Tyler Tolbert,
And I'm Dr. Soren Paape,
and you're listening to the Fix Podcast.
your source for all things implant dentistry.
One thing that we pride ourselves on here is having the clout to bring on the best implant surgeons in the world. And I think that we have not fallen short of that today. Today we have on Dr. Simon O, who, if you don't know him, then you're probably pretty new to Full Arch. So this is somebody that Soren and I have been following for a long time. I've actually interviewed him before, and he's graciously agreed to come back on and talk about all of his expertise. We're huge fans of him, of his Instagram channel, of his work, and also his work with Orca Global, which I'm sure you've heard of, as well as their upcoming symposium. So we're going to be getting into all that, but before we do, welcome back to the show, Simon.
Hey, thanks a lot, guys. Good to see you again.
For sure. So it's been a little bit since we've talked, and certainly things have grown, and we want to talk about all the updates that are going on in your life and career, of course. But for those who don't know who you are, would you mind just kind of giving us a brief introduction as to how you got into implants, how you got to where you are from dental school to here?
Yeah, sure. I reside outside of Philadelphia in the suburbs. I ended up here because I grew up in Maryland. I actually have only lived in two states, Maryland and Pennsylvania. Went to all the state schools, so University of Maryland College Park for undergrad, University of Maryland for dental school, and then I ended up at Hahnemann Hospital for oral surgery. Basically, I did that until med school, ended up leaving the program. And I was planning to move back to Maryland, but I met my wife. She was a med student at Jefferson at the time.
Mm-hmm.
She was doing a residency there, and then we're like, okay, we're going to go back now. And then that didn't happen. We had kids, and then, they had friends. And so,
Of course.
But yeah, in terms of implants, we didn't do too much when I was in residency. It was mostly trauma. Center of Philadelphia, level 1 trauma center, just gunshot wounds nonstop. That's basically like what we did. After I left, I picked up a position as like a traveling exodontist / implant person. Exodontia is really cool. I like it because just from a lifestyle perspective, like it's very simple. You meet the patient, they're in pain or they need their wisdom teeth, whatever, and you get them out. You say hello, goodbye, and then maybe you see them for follow up, and that's it. That's pretty convenient. But in terms of like impact, I'd say like the implants is really where things sort of like my focus went into, because that really made people happy. People aren't exactly happy to get a tooth pulled. They're happy to get a tooth restored. So, little by little, I started out with singles, did multiples, edentulous ridges. And then, at one point I was actually considering leaving dentistry because I was getting pretty tired of it. A lot of people were not exactly thrilled to see you. But then I stumbled onto Full Arch, started learning about it, reading about it, following a lot of guys on social and reading articles, reading the history. I really enjoy reading that. I just realized wow, you can actually, instead of just like a single tooth or a bridge or something of implants, you could do their whole mouth, change their life in a single day, give them function again, give them aesthetics again. That just changed the whole game for me. So ever since, that's pretty much all I've been doing. I haven't, I maybe place I don't know, 50 single implants a year or something, not really that much. But the full arches are just, that's all I do. So, in terms of impact, I really like it because, in anything in healthcare, you sort of treat a certain segment of health. So veneer people take somebody that's already healthy and makes them a little bit better, right? They're at the upper echelon of health. And then you have your middle segment, which is crown and bridge and just routine dentistry. And then you have the very bottom segment, the orally crippled people. And what that procedure does is we take those people and bring them all the way back up to here again. So I think it's just great. I love the work. I love the technicality of it. I love the sort of geometric aspect to it, like geometry. And I don't know if you guys remember the PAT from the
Oh,
DATs.
we remember.
Yeah, yeah. For me is just so interesting. So that's really that's all I really love right now. So
Cool.
I really like that analogy. I might have to steal that one of the three tiers. That's really good.
Yeah.
It's funny, Simon. I always say the same thing, and I've probably mentioned it in the podcast before, but something that I love about full arch dentistry is the fact that instead of your patients coming in for like a routine checkup and you telling them that they have a cavity and it being like the worst thing of their day, you're the people that are coming in to see you, they already know that a majority of them already know they need their teeth out, and you're there to provide them a solution. And instead of being someone's worst part of their day, you can really make someone's day. So I really love that about full arch dentistry as well.
oh, dude, yeah. I mean, and the people that you meet along the way, like for all the consultations that we do, like you hear their stories, and it's sad. A lot of them really live in the dumps, like mentally.
Yeah.
Yeah, that's I like sort of helping those people.
Yeah, totally. And I think there's just so few things in dentistry that you can do that so quickly improve all aspects of someone's health, physically, emotionally, nutritionally, everything that goes along with that. And kind of going along with what you're saying is like the kind of dentistry we do, like these are treatments that patients get to have done. They don't have to have done always. I mean, have to is kind of a different term, but they feel this opportunity. Like when you come in and say, yes, I can do this, they've probably already been told several times that it couldn't be done. They didn't have enough bone. And I know for sure that you're seeing cases a lot of times that have maybe already been done and things are going wrong and it's looking really bad. Or maybe a patient that just has so little bone left that they couldn't find anybody that said that something could be done, at least in a reasonable manner. Because, if anyone's familiar with your page and your cases, there's a whole lot of, quad zygo cases, Terry cases, things that are, combination remote anchorage and stuff. And we definitely want to get into that. But, just being able to make what patients thought was impossible possible is the coolest part. And seeing that surprise on their face, it really never gets old. It's very rewarding.
Dude, yeah. And, I've noticed an uptick in people with failing implants too.
Of course.
Like that's
Yeah.
one thing to have, failing dentition or just completely edentulous, but then you have the people who have already been through that, and then, so yeah, it's sort of getting a little more complicated, which is cool for on the technical side and the sort of interesting aspect. A little bit sad for humanity.
Yeah.
I could say
For sure.
I would say also I've seen an uptick in my office of I would consider them prosthetic failures, where they come in and maybe they went to a dentist who was just getting started with full arch, or who knows why, but they come in and their prosthetic is like basically a denture. It's so thick, and they're just like, Dr. Paape, I've been dealing with this for the last 2-3 years, and I keep going to the same dentist, and I don't feel comfortable in it. It's been like a nightmare, and I thought it was something that would be like an easy solution. So I find that kind of fun too, being able to take those cases, and whether it means sometimes replacing implants, other times just putting on different multi-units and trying to get them to a point where we can make them a prosthetic that's a little bit thinner, that they can talk with better, that they feel more comfortable with it in their mouth. I find that really fun and challenging as well.
Oh, absolutely, man. And, that's sort of like the best case scenario for, like, call it a revision, is small tweaks to get them comfortable. Yeah. I mean, dude, if we don't have to, put a scalpel in someone's mouth, that's a good day,
Yeah, definitely. I'm curious. So, you see a decent, volume of revisions. So the ones that you're seeing, are these kind of, from what you can tell, are these being done 10, 15 years ago? Like what's kind of comprises like the bulk of those revisions? Are some of them more recently but poorly done, or are they just aging at this point? Like, what are you seeing most of the time?
Yeah. I mean, I guess for my practice, it's probably different because, we get a lot of referrals for, for rescues and stuff. And if someone's having a hard time with the case, But yeah, I mean, I would say, I've certainly seen a lot of old school dentistry, like some of the first pterygoids that went in. Like I saw a bunch of blades from Linkow, like years ago.
Wow, awesome.
And like cases from so Tom Balsh used to practice near me.
Okay.
He was doing like the first pterygoids, the first like full arch sort of concepts that we're doing all the time now.
Mhm.
And yeah, I'm seeing a couple of cases like that come in, but I've also seen a lot of cases that are doing stellar of theirs. So it's kind of hard to say, but yeah, I mean, I would say a lot of the problems that I do see like on a day to day is more recent, in
Yeah.
fact. So that that sucks,
Yeah.
um, having to sort of go through this all the time. But it is what it is. As long as we're all doing our best and sort of keeping the patient's best interest in mind.
Yeah.
Yeah, there's no way that we don't have crystal balls to predict the future, but and see how certain patients going to turn out. But yeah, it's sort of a mixed bag, I'd say. But a lot of them, a lot more than I would think, are recent cases.
Yeah, it's interesting because, especially when you're seeing historical cases from people who you know of who, did some of those early cases and things. It's like you're a dental anthropologist or something, and you're just like, finding fossil evidence of like our history of what we do. It's really cool. But yeah, I think it's probably, you talk about seeing a lot of recent stuff, and I imagine that's sort of a multifactorial thing, right? Because so many more people are doing full arch now. Even if the rate at which those would be complicated was similar to how it was 20 years ago, you're still going to see a lot more cases just because it's become so much more commonplace. But at the same time, you may also have a lot of people who, because sort of the barrier to entry into this kind of thing has been lowered, you have people maybe getting into it a little bit sooner than they need to be, doing it improperly, not quite having the right training, or taking on cases they aren't aware of how complex they actually are prior to getting into it, maybe. So yeah, that's definitely interesting. I think that, for a lot of the people that are, have been doing full arch for a couple of years now, getting really comfortable with it, starting to identify as full arch doctors, what we also have to realize is that we're not just going to be like the primary full arch people for someone who's getting full arch for the first time. You really have to learn, historically, like what all these restorations were looked like, how to take them apart. If I ran into a blade, I'm not entirely sure exactly, how I rehab that and the best way to take that out and what to do with it. So learning that history and how all those things work prosthetically, the types of drivers you might need, how to pick these old cases apart and how best to revise them, conservatively is going to be a big part of it, because we're going to be fixing the new full arch surgeons' work as well. So I think that's just kind of a mantle that you have to take up as someone who, wants to do this exclusively.
Yeah, no, absolutely. I mean, the what sort of comes to mind is like in a dental search, like we all get it. We tilt the posterior implants 30 degrees,
Mm-hmm.
anteriors, somewhat straight if you can. Otherwise, tilt 30 degrees basically to avoid stuff.
Yeah.
What's going to get interesting is when we start to develop protocols or techniques for the revision. Like, I don't think anybody has really thought that through in terms of like, okay, this one fails. What do you do next?
Yeah.
Is it okay to have a constructed arch up front with pterygoids or something to avoid a zygomatic?
Yeah.
That's where I sort of I have some relief thinking about that, because we're having AI come in, and
Yeah.
so like we can. I think that complexity would be something that machine learning could be pretty useful for,
Yeah.
to sort of analyze. We can upload a DICOM file into the machine, and it spits out an algorithm of like, hey, this is your best chance of long-term success for this patient.
Yeah. Yeah.
Yeah, I really like that.
Yeah, I mean, we kind of see, that future coming on from different directions. Like we're getting new ways to get data, right? Like obviously our data acquisition is getting better on the CBCT side of things. We're getting good at arch tracing. We're able to map people's bite forces and things like that. And then, AI can go in there, kind of consider those types of factors, maybe parafunctional habits, occlusal dynamics and things, and then it can look and find, where our zygote is going to be best suited on this bone? Where are we going to be able to fit that? Is that really going to make sense? It can kind of analyze based on the arch form, how much tuning fork motion you're going to have on your anterior superior zygote, if it has to go way up front or something like that. It's really amazing to see, or to just think about where this might be in 5 to 10 years, and how we can really be assisted through AI and machine learning. But yeah, that's a great point. I'm very interested to see where that goes.
Yeah, I was listening to Elon Musk on an interview, just what his sort of predictions were for machine learning, and apparently it gets better by 10 times every year. So about, I don't know, 4 or 5 years, 10,000 times better. So it compounds. So the life and practice is going to look much different very soon.
Yeah, for sure. Yeah, we may soon be dinosaurs, and we'll just have yonis doing everything. Something of that sort.
Simon, I'm curious. We talked a little bit about your background getting into full arch. I'd love to hear a little bit about your progression through full arch, from just maybe traditional all on four to what courses you enjoyed the most, getting into remote Anchorage, and for someone who maybe is doing like some pterygoids or like doing all on four, what you'd recommend for to get them into like the remote Anchorage world. And I know you have Orca and some of these courses, but I'd love to hear your history and how you kind of started getting into that style of dentistry.
Yeah, I guess I first heard about the possibility, and I think I did what a lot of people who had been placing conventional single implants for a long time would say, which is like, that's crazy. You're going to load it right away. You got to wait. And so that really piqued my interest and caught my attention. So I just started reading. I read a lot of articles. I read a lot of textbooks on the subject matter, and it was very compelling evidence that this is a very viable and very good treatment option and protocol. But it didn't really. Like, you can take concepts and think about it and learn all the statistics and everything, but it doesn't really click clinically. Like, you have a jaw flapped open. What do I do right now? Like, where do I put these things? And so I went. I started placing them, the best way I thought, and I made mistakes along the way. In hindsight, I wish I did some sort of overseas conventional only live surgery course, because that would have made it click like very quickly with the right instructions, of course. But yeah, I made some mistakes along the way. I started getting better at it, but I started realizing, like, hey, some of these upper back implants aren't torquing. Like, what do I do right now? And then I would see other patients who just don't have that bone segment, and I'm like, I really want to help these people. So I started looking into zygomatic implants. That came first for me before the pterygoid. I didn't even think about the pterygoid. I was just like, zygos are cool. Like, look at those x-rays. But I sort of got obsessed with it at home, and started reading about it, exploring different brands, following other guys in social. And then I was like, I'm not going to do this. I'm not just going to try to shoot from the hip with this thing. So I went down to Brazil, a town called Campinas, and right next to Sao Paulo. There's really two really good guys, Abilio Copide and Thiago de Maio. Not very well known, but they're good guys. They actually, the Neodent rep hooked me up with those guys. So me and my buddy Alex Benner, we went down there. That's where I met Shivane Gupta. I don't know if you guys know him. He's in Georgia. He's a good guy, oral surgeon. But yeah, we sort of jammed out a bunch of zygos down there in this really sort of kind of a sketchy OR. There's 3 rooms. There's like a tummy tuck here, us, and then like some other body part procedure, and there was one anesthesiologist. And like at one point, like the suction went down, and we were like, "What the fuck is going on?" It was pretty crazy, man. But like it was fine, it was safe. Nobody got hurt. It was fine. But yeah, we were jamming out zygos. They had lined up like like a ton of cases for the week for us. So it was muscle memory, like, and that's what I wanted, which was like a very immersive course that you can just go boom, 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 and get like really tired at the end of the day, because that's when it really registers. If you just keep doing it over and over and over and over and over, understanding what the zygomatic bone looks like from the mouth. Like I had seen it during like trauma cases from here and here, but like never from like intraorally, and so like it's very new. And just extending a long drill in there, so that really made it click. And so like when I left there, that's when things really sort of took off, because I was able to treat every patient that came in the door. And yeah, that sort of that was like the inflection point for my full arch career, was that course in Brazil. After that, started getting into pterygoids. I'm like, oh, it'd be nice to get some back there. Started seeing some guys out there, like Dan Holtzclaw, Ramsey. I mean, like, the OGs of this space, Juan Gonzalez too. I was seeing placing pterygoids. I was like, that's really cool. Like, I could maybe avoid this, or this helps sort of stabilize the whole thing because zygos flex. So started reading about that, and just and started doing it. I created my own sort of algorithm along the way to make sure that I get into the right spots. You sort of pinpoint the hamular notch in the greater palatine canal. Just go right in between the two. You start at the level of the GP canal, because that kind of goes straight up, and you just start at the same interposterior line, and then you just go right in between the hamular notch and the GP canal. You pinpoint it. But yeah, that sort of that was like the next step. Like it was starting to go like that, and then you've seen like stocks and stuff do that. So that's sort of where it is. And then along the way, start seeing more problems. I want a solution for that problem. Some quads are going to fail. What do I do after that? Or like, is there a better way? So I noticed a guy, Vanderlim, on Instagram.
Yeah, we're familiar.
Transnasals. I was like, what the hell is that? Like, how are they going to breathe? But it turns out, like I lecture on this where it's very clever. It's sort of like a hack of the nasal cavity, because it does not obstruct airflow. You by X-rays, you're like, that's going to obstruct airflow. It does not obstruct airflow. So if you think like evolutionarily, whatever your faith is, like but from a functional standpoint, our olfactory senses are at the cribriform plate, which is the base of the skull, which is right above the nasal cavity. That's where we smell stuff. So, functionally, all the air goes up there. So if you see there's a technique called acoustic rhinostomy or rhinometry, acoustic rhinometry. My brother-in-law is an ENT, but there's a technique where you can measure airflow, and actually goes way up high to the superior turbinate area, and the airflow is the lowest where that implant is. So it's pretty awesome. Yeah,
okay.
It's great.
So you're saying that it's kind of like a wind tunnel that goes not in the direction of the inferior concha, so there really shouldn't be anything along that path. Anything along that path is not really going to obstruct the airflow, despite what intuition would suggest.
Yeah, no, exactly. And think of like what's out there in all of mammals. Like smell is a big way to detect a predator.
Yeah.
And so it would make sense for that sense, or for the airflow to go where the freaking
directly to where the olfactory receptors are going to be. Yeah, that makes sense.
Exactly. So it's like it's such a smooth, sort of sneaky almost way of getting anchorage up front in the anterior maxilla without creating any functional harm. It's pretty cool.
Yeah, that's interesting. So I'm curious about you mentioned Juan, and we've talked to Dr. Sammy before, and Holtzclaw as well, and the Patsy algorithm gets thrown a lot, and I think they've done some incredible work in really trying to codify that into something that's easily digestible and helps us understand how a fully remote Anchorage certified surgeon thinks through an arch. Would you say that is really part and parcel how you think about full arch, or are there kind of some nuances about the types of techniques that you will go to first, what you start with, things like that?
Yeah, no, that's a great question. I think Patsy's a really smart way to approach it. Um, I would say that there are definitely times where I go for that, where I place the pterygoids first. That way, you know what's going on for the rest of the arch. But I'm a creature of habit, I guess, and I always start with the anterior. And if I'm questionable about the middle, yeah, I'll do the pterygoids second. But like for me, I want to get warmed up. I want to get
Mm,
get the turbine spinning. So I
yeah.
always do the foot first, just out of habit, I guess. But I don't think algorithmically it really changes anything if you place the front first and then the pterygoids, because if the front doesn't work, what's your next option? It's basically the same algorithm. So I don't.
Yeah.
To me, maybe I'm wrong, but like I don't think it necessarily, at least on a conventional arch, I don't think it really
Yeah.
changes much.
Mhm.
But yeah, I mean, the reason why I go up front first is because the anterior bone for the upper and the lower is always going to be better than the posterior, right? We all know
Always.
that, at
Always.
least the tilted. So I use the anterior as a litmus test. So I
Mm,
will I will do my normal protocol. I'll drill, if it's a 4.2 implant, I'll drill to about 3.2 a lot of the time,
Yeah.
and I'll see what the torque is. If I'm just at 35 Newton centimeters,
it's
I
not getting any
now
better.
know that I'm not going to do any better with the same protocol in the posterior. So
Yeah.
I
Right.
just under prep it after that. Use Denzibers. So that to me, it sort of gives me the best sense. And then once I've built my confidence, that's when I feel good to hit the pterygoid. So yeah, maybe there's like an emotional,
Yeah.
like an anxiety protective kind of feature for me to not do the pterygoids first. Because like if I miss my pterygoids, I'm like, oh, like what am I
Then
going to do
things are
now?
different. Yeah.
Yeah.
Yeah,
Yeah.
we
I
get
can
all
actually,
flustered.
I can totally relate to that because there's definitely a point during a surgery where you got the critical implants that you need, and then everything else is kind of just like, we're good. I got the
Yeah,
case. Like it's secure. It's
icing
like
on the
nothing's really gonna go wrong at this point.
Yeah, exactly.
Yeah, yeah, that
So
makes
Yeah.
sense.
because I mean, you guys get it. It's a high stakes game.
Yeah,
Like if
Yeah.
we don't hit our numbers, we're not going to be able to deliver the promise to the patient. They're going to be really upset.
yeah,
Yeah, I think just from like a mental point of view, pterygoids first kind of freaks me out a little bit. I
I
mean,
see.
if I
Yeah,
have to do it, I will, but I definitely like to go up front first.
that makes sense.
Yeah,
That makes sense.
I do the same thing. I like to get my security with my front four.
To know you have a
And once I
case.
have my front
Yeah,
four, I know, okay, I can load this case regardless. And then for me, it's like I can add a little more support on for those tilted implants and a little more, more teeth for the patient if I get those pterygoids in. But if I miss them, the patient's still going home with a loaded prosthetic, and I don't have to have a conversation with them about why maybe the case wasn't able to get loaded. So I agree with that. I mean, I think it is a sense of security where you get your front four, you get the prosthetic to a point where you can load it for the patient, and that way, no matter what, the patient's going to go home happy. And then just adding that extra security of placing those
yeah.
pterygoids goes a long way.
Yeah, I think the only nuance I can think of when it comes to being anterior first, and I think obviously your whole mental calculus is different when you know that you're in a severely atrophied situation. But um, Juan was talking about in a case that he knows that is going to be a zygo case, he will in the anterior go for a nasopalatine and try to get that to reduce how far anterior the anterior superior implant needs to go so he can use a shorter implant and reduce that tuning fork capability. So I guess like it doesn't necessarily mean that you can't go the anterior first, but you kind of already have to have in mind what's going to happen after that to determine whether maybe you're going to do transnasals or you're going to try to do two in the front or whatever the case may be.
Yeah, that's interesting. I never thought of it that way, and I talk to Juan like all the time.
Yeah.
So like I'm surprised that we haven't talked about that, but that makes a lot of sense because the lever arm on say a lateral incisor
Yes.
position on the anterior superior is pretty far. Even though it's just one tooth segment over, I would have to think that it's sort of logarithmic with the amount of flexure the longer
Yeah.
you go. Um, So yeah, that makes a lot of sense to go for the nasopalatine position and then sort of load it from there. For quads, I have always done the nasopal or the midline nasopalatine implant
Mm-hmm.
last for some reason.
Mm-hmm.
Because there was a study that I read that the all-on four or the four implant configuration with one zygo on each side, two conventionals up front, had a
Mm-hmm.
higher rate of failure of the anterior conventional implants. And to me, my hypothesis is that the
Okay.
posterior implants are flexing, putting a
Yeah.
lot of stress on smaller implants. So
Hmm.
I would have to think that the fail rate on a nasopalatine implant with the quad segment would be higher. And so I'm just one. I don't know what the answer is, but
That's
um,
interesting though. Yeah. Yeah.
yeah. So like, say it does fail, or you have a patient that is high risk, or the torque is only 30 or something. Would I have rather have less anterior cantilever with uh, anterior superior zygos going more anteriorly? I don't know what the answer is to that.
Yeah.
But that's
Yeah.
definitely a discussion I think we need to have.
Yeah, for sure. And I think too is like, with kind of pioneering these algorithms, we don't have really the luxury of tons of data, with all these different configurations in mind to really know. Like a lot of this is more intuitive and just kind of thinking about biomechanics. It's not necessarily in the numbers. We can't really look at the force vectors over 10, 15, 20 years. And so, for the most part, we're just kind of shooting shooting from the hip and doing the best we possibly can. So, but of course, it's important to plan for failure, and I thought about that too when I heard that. I was like, well, if you lose the nasopalatine and you kind of scooted back your anterior superior implant, and now you've got this huge anterior cantilever, have you kind of compromised the case a little bit in that way? It's hard to say, when you don't really have a ton of data to compare.
Yeah, for sure. I guess what it comes down to is the decrease in flex, the decrease in flex enough to have increased survivability of the nasopalatine implant
Yeah.
to the point where it really makes sense to do that. And that's sort of, I think we need engineers to sort of
Yeah,
help.
probably people better with numbers than us.
Yeah, because there's materials involved. Like it's going to be different for grade 4 titanium versus 23 or 5. So like,
Yeah.
yeah, I mean that's all. Again, I hope that freaking ChatGPT can help us with that.
Maybe
Right?
it can. Yeah, ChatGPT. Well, based on what Elon said, by next year we don't even need to record this anymore. We just
Yeah,
we'll just
right.
say it's a conversation between these three guys, and it'll use our digital avatars and make the whole episode. It'll be great. Yeah, that's awesome. So you recently posted a case, and it was really auspicious because Soren, myself and our third partner, Caleb Stott, were having a conversation because a case had come through Soren's clinic where he had a patient he was a younger patient with a high smile line and very severely pneumatized sinuses, not just pneumatized, but those with like the Kelly syndrome where it kind of is actually coming sort of almost into the plane of occlusion. And there was no way with reduction to hide the prosthetic line. And so we were talking about options with, up fracturing the sinus floor, doing lifts on both sides, coming back, alveoling later. And then it was, I think, either on that day or the day after you posted your case of doing literally the exact same thing. So I was wondering if you could just kind of expound a little bit on that and just kind of talk about how you thought through that case and how you approached it.
Yeah, I sort of recognize that sort of complex case conundrum several years ago when, yeah, I mean, because we all look at the Duchenne smile, the
Mm-hmm.
big smile,
Mm-hmm.
when we evaluate like where a reduction plane is going to go. And yeah, I mean, in terms of solutions, I didn't really have much. I mean, there's always times where we sort of kiss the sinus floor on our reduction. Like we always see
Yeah,
that.
all the time.
But like, what do you do when it's like way higher than that? Is that going to seriously injure our patients? Is there a one-step option to sort of fix this problem? So I started doing like an up fracturing technique. So similar to what you said, I used to
Yeah.
take a piezo and sort of cut like one in the middle and then crosses, like sort of like a pack of ice cubes, or ice tray.
Yeah.
I would do that and then sort of try to tap it up, because my thought process was, okay, well, we'll still have periosteal attachment to those bone segments, so that'll be fine. That the segments might actually create a little bit of stability of the sinus floor.
Yeah.
And what I did after that was I would take something that would, a biomaterial that would harden to an extent. And so I used Ogma for that, which is hydroxyapatite biphasic calcium sulfate. It becomes hard. So I did that. But I found that, like, it had good success, but the times where it didn't work were bad.
Yeah, terrible.
We would have a sinusitis or antial fistula, like, oh God, what a nightmare. So
Terrible.
that to me, made me really sort of careful with how I approach those cases. And so, just maybe I'm getting older and I'm like tired, but I don't want to deal with that, like complications.
Yeah.
Like, if I can avoid it, I will. If somebody's if somebody twists my arm, I'm not like a robot, I'll think about how they're feeling about it. But ultimately, the way I've sort of been handling it these days is serial sinus lift, and then go in, do your reduction plane. Even if the sinus bone doesn't convert and it's just powder, at least you have some sort of biological barrier between the sinus and
Who cares?
cavity. Yeah. So who cares if it's living bone or not? It's as long as it doesn't get infected, you know what I mean? So that to me is it. And, if you do a zygomatic, it'll be nested in a nice little thing, So that's sort of how I approach them. I like predictability and sort of, getting these people through smoothly. Yeah, I mean, if you can, I guess the hard one is the edentulous patient with that, because, like, if somebody has a few teeth, you can give them a partial for a while they heal, and let the sinus lifts heal. But the full denture patient, I guess, they sort of just have to. I guess they've been in a denture for a long time,
Right.
but yeah, it's not really an easy thing. That's one of the reasons I'm really looking forward to this product called Tetranite, which is made by Rev Bio. So those guys are smart, dude. So, like, they took a protein from one of the only creatures that can create adhesion in water in the ocean. They took that protein. I don't know if I'm allowed to say what it is. I forget if I signed an NDA, but they took that protein and put it in bone grafting material. I'm sure you guys have heard of it. So, like, I tested that stuff is crazy. So, like,
Yeah.
it comes like in a little amalgam, or like the cement container where you, like, put in the shaker, take it out, you put in that
the triturator.
Triturator. Yeah. So
Yeah,
Whatever
it's been a minute.
Yeah.
yeah. So it comes in that thing. You squirt it in. It becomes hard within like 5 minutes or something.
Yeah.
And I tested it where it was an empty hole. I injected the material, just sat an implant into it, let it set. It torqued to 45 Newton centimeters when it set.
Money.
So
Wow.
that stuff is rock hard. Like, you can bang on it. It sounds like I don't know, plate or something. So I'm just wondering if that is going to change things. I don't know what the sort of blood flow requirements of that is, and there's going to be a lot of sort of research and development of, like, what the proper protocols to convert that into bone are going to be. But, like, if that can repair a sinus floor, that would be amazing. Or if that could sort of, like, wipe it over the up fracture, if that could be a viable option, that would be sort of revolutionary. I think a lot of people, at least the people that are careful enough that can think through these kind of patient problems, that's going to be revolutionary for everybody.
Yeah, and if nothing else, if it couldn't sustain an implant long term for, I don't know, blood flow reasons or whatever, I'm not even sure if it's that relevant with that type of material, but it's still that inert barrier, kind of like what you were talking about. Instead of just counting on the sinus grafting bone to heal after 6 to 9 months or whatever, if it just instantly hardens right there, you've already got something that's going to, support it and might actually be an instantaneous solution, because you could just go ahead, lift the sinus floor with that material, do your alveo, and just finish the case. I mean, that would actually be an instant thing. So that's really cool.
Yeah, I actually called Simon about this case. I think I talked with you and I talked with Chris Barrett, if you're familiar with Chris. And because I was like, I really wanted to help. It's a young patient. He's, I think he's like 30, and at least in my benefit, he's kind of had his teeth at the gum line for 3-4 years now. So he hasn't had teeth in so long. And I wanted a solution for him in a day, right? I mean, like, that's always kind of the goal. But in his case in particular, I had the conversation with him, just let him know, like, hey, your best bet by far is if we could do bilateral sinus lifts, let that heal for about 5-6 months. And then at least we'll have, when we go in and do our alveoloplasty, we'll have something supporting the sinus floor. Otherwise, you could end up in a situation, like you said, where if we end up with an oral antral communication that we can't repair, you're going to be in much, much worse shape than you are now. So you've been 3 years without teeth. It might be another 6 months, but the chances of survival of that case are going to be much higher than trying to get it done in one day. And as a young guy, right, 30 years old, he's got a long life to live with these teeth. Like 6 months is a small portion to pay for something that I think is going to be much better suited for him.
Absolutely.
One complication that I'm having with this case, and I'm curious how you treat it, is that his right sinus is like completely full. I think it's because of his dentition. Like, he just has a bunch of roots in there that are just causing infection. And I think I saw him at like December 1st, and I asked him to go to an ENT to see if he could do like a fest, right, to clear it out. But let's say that he came into your clinic and he didn't want to go to an ENT, would you still do that sinus lift? Would you maybe make a small hole and clear the sinus out yourself? How would you manage that?
No. So so the scenario is a 30-year-old or 30-some-year-old guy with poor dentition, so like root caries or like caries into the pulp, that sort of situation. Yeah. So if the sinus is completely opacified, I would not do a sinus graft. I mean, the sinus has to be healthy in order for that to work out.
Mm-hmm.
What if like, say, health insurance is an issue, which it sometimes is. What I would propose to him to sort of work with him would be to remove the teeth that have protrusion or proximity to the sinus and see what happens. Who knows? But yeah, in terms of grafting or even zygomatics or transsinus implants with the opaque sinus, I would get that cleared up before you do anything else.
Yeah, I have a call with him tomorrow, and hopefully he's seen an ENT in the meantime, and maybe he's gonna have a solution for that. But if not, my plan was remove the teeth first, see if we can get some clearance on the sinuses, and then go do the large sinus lifts, and then in some time come back, do my traditional all-on-4 with pterygoids probably, or however. We'll see how the sinus lifts heal. In the case you recently did, do you know how much graft you used to lift those sinuses?
All of it.
I think, we lost. I lost count after 10 cc's. Yeah, I don't remember because I was just like, oh my god, it's not stopping. Like I'm like shoveling the stuff in there, and like run out of bone. I'm like, I need another. So like I would, if I had to guess, it would probably be 12 cc's. It was combined with sticky bone or like, PRF, LPRF. Mm-hmm. So that was interesting.
Yeah. How do you know when to stop?
It's a very subtle thing. So the way that I tested, I sort of got a sense of like, okay, if I poke the window with my finger, it feels like this much tension. And that's
Okay.
when to stop. I can't really explain it to you. Because like if you push too hard, it's gonna burst. And like bone's gonna go freaking everywhere. That's
Yeah.
like horrible. So I fill it up until it gets into the window. I gently push to see if there are any pockets where it's not stuffed
Yeah.
in, and then keep filling it. But yeah, I mean, there's sort of like a tension type feeling that I sort of got used to. Very light, not very light.
Yeah. And with regards to the window, what for a case like that, what's the most strategic but conservative place, and what kind of size of window do you really need?
Yeah, for that case, I couldn't afford any perfs, so
Yeah.
because of how much I wanted to get done. So I made a window basically expanded from anterior to posterior, except I didn't go as far back as the tuberosity. I sort of had enough access because, we see things from anterior. So I could sort of peek in there without sort of getting rid of that bone.
Yeah.
But yeah, I mean, I would probably guesstimate about a centimeter in height from anterior to probably like the first or second molar area.
Okay. It's significant.
Um, yeah, it's very significant. But I always make sure to leave a shelf of bone. It's not at the floor of the sinus. That way it can sort of hold it. And I always try to keep the windows away from the incision line. Because if you keep
Yeah.
both at the same area, you sort of risk problems by doing that. So I always try to offset them somehow.
Keep it remote.
Yeah, but about a centimeter in height, enough to get the entire side action sinus curette in there.
Okay. Okay.
Yeah, that was my plan. A long, thin window all the way across. Because again, I can't perf it either. Like if you perf, then
Well.
then we're in a really bad spot. So that was my plan as well. With that case in particular.
Yeah. So.